Hi, everyone. I would love to welcome our panelists up to the stage. I'm getting started here. So it is a pleasure to be able to moderate this next session. This is our third iteration of the Armchair conversation on colorectal cancer health equity, barriers, solutions, and this year we are targeting the Asian American community, so it's really excellent segue from what Becky just presented to us. And I'll maybe individually, I'll ask our panelists to kind of introduce themselves a little bit later when they have their own remarks. At the beginning, I would just like to kind of set the stage for the population that we're talking about. And the challenge of discussing Asian Americans is partly what Becky had already alluded to, is that when we talk about Asian Americans, you're really talking about people who are living in this country with a shared ancestry of coming from Asia. And that's a very large area that we're talking about, extremely heterogeneous. So we're talking about 49 different countries, which accounts for 60% of the world population, hundreds of different languages. We're talking about Asian Americans. It's nearly 26 million individuals, 7.2% of the total US population. And this includes very large groups with more than 4 million individuals, so including the Chinese population, the Asian Indian population, the Filipino population, but also includes very small groups that we don't often hear about, of people with less than 40,000 in this country. So Mongolian population, Bhutanese, Kazakh, for instance. A very large percentage, a majority, 57%, were foreign-born. And there are wide disparities in terms of English proficiency, education level, and income. So the bottom kind of right figure shows the percentage of individuals from different Asian American subgroups who are in poverty. You can see it ranges from 6% for Asian Indians to all the way 25% for Mongolian individuals. So, we did our very best to try to assemble a panel with a diverse set of experiences, expertise, but the caveat being we're not going to be able to talk about every individual kind of group. And so, we'd love to kind of, after we have our kind of individual kind of presentations and prepared kind of questions, to get all of your insights as well. So with that, I'm going to turn it over to Dr. Christina Wang.
Thank you, Peter. I'd like to I'm Christina Wang. I'm a gastroenterologist at Mount Sinai based in New York City, as well as a clinical researcher focused on improving colorectal cancer screening rates in the Chinese community. I'd like to thank the conference organizers for giving me the opportunity today to speak with you guys about a topic that's incredibly important to me. So why don't we get started? My only disclosure to report is that I'm supported by a NIH Career Development Award. To provide some background, the Asian American population remains the fastest growing racial group in the United States over the past 3 decades. Between 2010 and 2020, the US Asian alone population increased by 35%, compared to an overall 15% US population increase. The rapid growth of the Asian American population is driven by immigration as opposed to native births. By 2065, it's anticipated that immigrants and their descendants will account for nearly 90% of US population growth, with Asian Americans projected to become the largest immigrant group. Historically, in most national surveys and health systems data, Asian groups are often aggregated, rendering many groups invisible and masking important social and health differences. In the healthcare setting, categories for race and ethnicity generally follow the Office of Management and Budget categories for race, which include American Indian or Alaska Native, Asian, Black or African American, Native Hawaiian or other Pacific Islander, and white. So why does this matter? Without more distinct categories for ethnicity, potential health disparities within these broader racial categories are concealed in the aggregate data. Data disaggregation helps to challenge stereotypes, such as the heterogeneous Asian American population being uniformly considered the model minority. The downstream effects of these stereotypes is that they perpetuate a false sense of well-being that deprioritizes research and funding for our communities. Every 3 years, the American Cancer Society provides an update on colorectal cancer incidence and mortality in the United States. And as we are well aware, there remain substantial disparities in the burden of colorectal cancer by race and ethnicity. As you can see on the left, American Indians and Alaska Natives experience the greatest incidence of colorectal cancer, followed by Black Americans, while Asian Americans and Pacific Islanders experience the lowest incidence according to national data, and these trends are similar for mortality on the right. This study is a comparative analysis of age-adjusted incidence rates for endoscopically screenable cancers across major racial and ethnic groups, including disaggregated data for the 8 most populous Asian origin groups. I present this SEER study that our group performed as an example of the issue with data aggregation and how that can obscure important health disparities within individual Asian origin groups. I want to specifically draw your attention to the dark blue bars, which marks the burden of colorectal cancer. In our study, we discovered a rate of colorectal cancer in Japanese American and Pacific Islander men that actually paralleled and even slightly exceeded the burden of colorectal cancer in Black men. From the vantage point of cancer risk specifically, our findings underscore the need to analyze cancer data across ethnically disaggregated Asian American groups, given their differences in cultural practices, diet and lifestyle, among other clinically relevant factors. Our latest screening metrics from 2021 reveal a national colorectal cancer screening rate of 59%, which we know remains below national benchmarks. This table, published by the American Cancer Society, displays colorectal cancer screening data across a variety of sociodemographics. Unfortunately, disparities exist across several factors, including major race and ethnicity, and as we know, Asian Americans experience the lowest colorectal cancer screening rates. Furthermore, by immigration status, recent immigrants experience lower colorectal cancer screening uptake compared to more established immigrants or US-born individuals. Here is data on completion of screening colonoscopy in New York City, dating back to 2003. And while the racial ethnic gap has begun to close, as you can see, Asian Americans and Pacific Islanders consistently demonstrate the lowest colorectal cancer screening rates. Nativity and time spent in the United States are important factors that appear to impact colorectal cancer screening uptake. This study examined the prevalence of colorectal cancer screening by immigration status and race and ethnicity, adjusted for a variety of different factors. In fully adjusted models, differences in colorectal cancer screening were fully attenuated among more established immigrants and remained among recent immigrants. Findings also differed by race and ethnicity. Among white and Black individuals, colorectal cancer screening uptake was lowest only among recent immigrants. While socioeconomic and healthcare factors explain screening patterns among more established white, Black, and Hispanic immigrants, all foreign-born Asian Americans and Pacific Islanders experienced low screening uptake regardless of time spent in the United States. Disaggregation is thus critical for exploring factors such as cultural health beliefs that may be particularly relevant for Asian American Pacific Islander groups, as well as differences in health behaviors that sociodemographics alone fail to explain. And as we've discussed this morning, we know that a major issue remains closure of the screening loop with regards to completion of a follow-up colonoscopy in the setting of a positive stool-based test. This is a retrospective analysis that used de-identified administrative claims and electronic health records from 39 different healthcare organizations. And in this cohort, we see persistent racial disparities with follow-up colonoscopy, where completion was significantly lower in Asian and Black patients compared to white patients. I want to now spend the rest of this talk sharing some findings from focus groups we've conducted in the Chinese community in New York City. And as we've heard earlier, Chinese Americans are the largest Asian origin group in the United States, and the New York City region is home to the largest Chinese American population of any metropolitan area. Chinese immigrant women are a particularly disadvantaged group who are adversely impacted by the social determinants of health, and colorectal cancer is a leading cause of preventable cancer death in this group. Unfortunately, screening rates are suboptimal in this group as well. And we also know that multi-level barriers to cancer screening exist at the system, provider, and patient levels. So we've just finished conducting focus groups of our community stakeholders, which we believe are critical for gathering information about community concerns. Stakeholders are individuals who work at Chinese community organizations and have experience providing social or health-related services to Chinese immigrant women. In these groups, we explored stakeholders' understanding of structural and cultural barriers to care, as well as methods to effectively engage Chinese immigrant women in cancer screening programs. We are now in the process of conducting one-on-one interviews with Chinese immigrant women, which will be critical for understanding decision processes and exploring attitudes and beliefs about colorectal cancer screening. So we conducted a total of 5 focus groups in New York City with 22 total stakeholders. A majority of our participants were aged 25 to 40, identified as female, non-Hispanic Asian, and were born outside of the United States. All of our participants spoke Chinese dialects in addition to English, with a majority of our participants fluent in multiple dialects. Finally, our stakeholders held a range of positions in their organizations, such as program director, case manager, and social worker. So regarding health beliefs, one theme that was identified was a clear underperception of cancer risk. If there are no symptoms, don't touch it, especially cancer. If I don't do the screening, I don't have cancer. They don't have time for prevention. They don't even have medical insurance. They will wait until there are symptoms, then they will maybe try to find out more. A second theme that emerged was the concept of differing healthcare approaches between Eastern versus Western medical care. Culture is very important because they do believe in Chinese alternative medicine. So before they physically show up in front of Western doctors, they will turn to the Chinese way of treatment. That is why I have to train the doctor, because they will give the patient options, option 1, 2, and 3, and then the patient looks very helpless. And then I have to pull the doctor aside. I explain to them, in the Chinese population, they treat the doctor as an authority figure. So if you want to give options, that's fine, but you have to be more directive. For example, some doctors say, if you were my parents, I would have you do this. Then the patient knows how to follow. The impact of social influences on health beliefs was particularly strong. They will agree with the doctor, but they have to ask people who speak their language and their friends. Then they will make a decision. If a friend sees me, for example, go on the mobile mammography van, she may think, oh, she must have some problem. That's why she needs to do the screening. It's not for prevention, it's because she has a problem. So I will feel bad. I don't want people to think I have a problem. I don't have a problem, but people will think that way. Like if I know she does a screening test, I'm like, are you okay? And if you say no, it's just for prevention, people don't understand. Once you get on the van, that means you have something, and then the rumors the next day. Moving on to barriers to cancer screening, one theme that was identified was mistrust in the physician and the healthcare system. They are concerned with, is this test necessary, or is the doctor trying to make money? They have a van system, for example, that takes patients to the hospital, but sometimes they don't bring them back, and they don't know how to come back. They've heard bad stories about Access-a-Ride and how clients got stranded or the driver did not pick up the phone, so they're scared to get on any kind of transportation provided by the insurance company. A second barrier to cancer screening that was identified were the potential consequences of detecting cancer. I could tell there is a financial strain. Next thing you know, if the cancer is officially diagnosed, the money keeps growing. Let's just say they have to stay in the hospital. Next thing you know, it's like $20,000, and you're giving all of this money, and then it doesn't work. So pretty much the idea of finances, it's like they don't want to go through with it. They'd rather just have the mindset, I don't care to know. If you have cancer, that means you are a burden to the family, and the patient themselves feels so bad to give extra work to the family. Also, the family member will get tired, like, oh, you got cancer? What am I going to do? I'm going to lose my life to take care of that family member. Language differences, as you can imagine, were identified as a significant barrier, specifically related to interpretation and the potential for misunderstandings. Even if you speak the same language, it doesn't mean you understand the situation. You translate just the words, not the meaning behind them. So I think that is the big problem. Interpreters never say something to make them feel comfortable. They just interpret what the doctor will say. They won't say any extra words. We do have clients who have had bad experiences with the dentist, for example. This is where I'm hurting, but the dentist works on the other side, even though I mentioned it many times, and then that costs them, or the original problem is not fixed. So with the bad experiences piling up, I'm already poor. Rather than do screening, I'll stay where I am. Terminology issues around the concept of screening and even the colon were identified as barriers. The word screening is a mouthful, it's a concept. It's more of advanced language, it's not a day-to-day thing where, oh, I have to eat, I have to sleep. I think screening in Chinese is not a widely used word. Breast, you know, in Chinese is easy to understand, but colon, some people may not know where my colon is. I think they know hemorrhoids more than they know colon. Finally, I want to share with you guys some perceptions about colorectal cancer screening that particularly stood out. The time you have to spend on it, this is definitely a big barrier for people who work. I want to do it, but I know that I have to prepare like 3 days before. I just hesitate to make the move. So everyone hears the word colonoscopy, they're like, oh my God, I'm going to have to do this. I really don't want to do it. It's really word of mouth that colonoscopy has been one of the more evil tests. This goes back to the stool tests. I don't think that needs a lot of preparation, but we're not aware of that as an option. So when I think about colon screening, I immediately jump to colonoscopy. I wouldn't even ask, what are you talking about when you talk about screening? I would assume it's a colonoscopy and make the decision to say no. Lastly, to share some facilitators that were identified, our stakeholders stressed the importance and need for better education. I think education is very important about the treatments or survival rates. If you catch it early, what's the survival rate? So they know the benefit of screening, not just finding out that you have cancer, but what's next. But then you have to tell them why it's important. You catch it early and your survival rate is 10 or 20 years. But if you catch it end stage, then you may not have time to get treatment. I think lots of time they think, I got cancer, then I'm done, so then why do I have to find out? Finally, how we frame the message around cancer screening is incredibly important. My mom avoids saying cancer. She feels like it means death. However, I'm always talking to her about cancer, and I tell her, you can do the screening, it's easy, and it doesn't mean death. Because my coworkers are cancer survivors, and my mom sees them, and she says, oh, they look healthy. And then she prefers to do the screening. I think because I always talk about screening in a positive way, cancer doesn't mean death, it doesn't mean you will go away, it means it's a challenge in your life. You will get better, and she feels much better. Just like a long time ago, diabetes, hypertension, all is not a good disease, but now it's very common. Everybody has hypertension, everybody has diabetes. And it's okay, get the treatment. But now cancer, it's the same thing because there are so many cures, so it's not a bad disease. It's not taboo. It's not a curse. So talk more so people think it's common. So to conclude, disaggregation across the data lifecycle is incredibly important, and I hope that's the message you take away from this talk. It starts with better data collection to improve visibility of our Asian American and Pacific Islander communities across multiple domains. Next, we need to maintain disaggregation efforts in our analyses of exposures, outcomes, and epidemiologic trends. Dissemination helps to support visibility and representation of these populations. And finally, usage of this data will lead to the design of culturally and linguistically sensitive programs, better identification of ongoing barriers and challenges, and eventually targeted policy to reduce disparities in our communities. I want to thank my community partners without whom this work would not be possible, as well as my team based at Mount Sinai. Thank you for your time.
Thank you so much, Christina. Next, I'd like to ask Dr. Samar Aslam to share her comments. Dr. Aslam is a primary care physician in the Dallas-Fort Worth area from Advocate Primary Care.
Mm-hmm. So my name is Samar Aslam. Thank you for inviting me. I'm really excited to be here and join you all today. I've been practicing family medicine for about 8 years now. And being Southeast Asian, I have attracted quite a few Southeast Asian patients. And I know in residency, we were kind of drilled that the gold standard for colorectal cancer screening was colonoscopy. And when I got into practice, I found that talking to patients, especially who were Southeast Asian, that didn't really translate. Some of the main barriers I have found when talking to patients has been just lack of awareness. They don't know what is colon cancer, what is colon. You have to really simplify terms because they may not have ever heard of colon cancer, especially first generation immigrants. There's not much conversation because it may be a little bit taboo to talk about that area of the body. So really spending time educating patients on what exactly is colon cancer, where the colon is, and how some of the symptoms might present. Also, letting them know that just because you don't have symptoms doesn't mean that you might not have colon cancer. The importance of screening and catching cancer early, I try to really overstate that as much as I can because another big barrier is fear. Dr. Wang, you talked about that, and I find that to be one of the biggest barriers is, well, if I don't know, then I don't have to worry about it, and ignorance is bliss. My best friend in college, her mom was told over and over, you need to go get your colonoscopy done, and she didn't, and by the time she had symptoms, it was stage 4. So if she had just let go of that fear and gotten the screening done, then perhaps things could have gone differently for her. And so really just trying to relate to the patient that if we catch this early, then it's much more manageable versus if you just are scared and don't do anything about it. Another big barrier is lack of, or the distrust of the medical system and not trusting your physician. It's so, it's hard for every physician, every primary care provider, I'm sure, to try to establish some type of relationship with your patient in a 15-minute time span, but I can't overstate that either enough, is really trying to connect with the patient when they come in and form a relationship with them so that they trust you, because you could talk about educating the patient till you go blue in the face, but if they don't trust you, they're not going to do anything. So really just trying to gauge their understanding and of cancer, or just in general of the health system, to try and see what their concerns or fears are of getting the screening done, and trying to reassure them so that they feel like, okay, this is something that I can do and I don't need to be scared of. And if you don't establish that relationship, then they will go home and talk to a friend or a family member, and they'll say, no, I had that done, don't do it, it was horrible. So you may not be able to establish that relationship in the first meeting, but hopefully you can see them, over a period of time, and then maybe not in the second or third visit, but in the fourth visit, they finally do trust you and say, okay, you've worn me down, I'll go get the screening done. And then another helpful thing I have found is if they're just absolutely against getting a colonoscopy, offering other type of testing. Stool testing I have found to be very, very helpful because they don't have to leave their home, they don't have to take time off, they feel more comfortable that it's in their safe zone. They're at home, they don't have to deal with possible other costs. They know that everything can be done in the comfort and safety of their own home. And not only just telling them, oh, you can do a colon cancer screening at home, but really educating them on, okay, when you get the colorectal cancer screening in a box at home, open it up immediately, put it in your bathroom so that as soon as you have to go to the bathroom, you can collect your stool sample and mail it in. Otherwise, the box I find sits there, and I've had a few times where patients will collect a sample and come to find out that the materials were expired. So that's a whole other issue. So just really educating patients on, okay, we don't have to do a colonoscopy, we can do stool testing, but this is how it works. And then what's also, like I mentioned a little bit earlier, is the concept of the colorectal area in certain cultures can be taboo. So being cognizant of that and being sensitive to that, especially for me as a female speaking to a male patient, or vice versa, trying to really be sensitive to that and speak in a respectful, but also still manner that they will understand what colorectal cancer is and why the screening is important. Having them understand. A lot of my patients, they are first generation, they'll have insurance, but they don't understand how it works. You don't have to worry. This is quote unquote covered in your insurance. You won't, you shouldn't be hit with a big fee because they feel that, oh, I'm just going to have to pay a lot of money, and then they'll find cancer, and then kind of what you touched on, then I have to pay more money. So trying to educate them on how their insurance works, and that it's better that you go get this done now versus if you have to do it later, then it may be more financially costly. So those are the main barriers that I have found. Also the concept of preventative care in general. In Southeast Asian patients, I know for my own parents, they grew up in Pakistan, there is no concept of insurance, of healthcare. You only go to the doctor if you're sick. So the thought of coming in just a checkup, let alone a colonoscopy, is just so foreign to them. So really trying to help them understand the healthcare system here. Even second generation, I've found people who have grown up here because of what their parents have told them, don't understand what benefits they are due or owed based on what their insurance offers them. And so just really spending time to educate both first generation and second generation, all these Southeast Asian or Asian patients on what is available to them, so that they don't feel like the burden is going to be completely on them, that there are resources for them, and you're paying for your insurance, you should take advantage of it. But those are what I have found to be the biggest barriers. Mm-hmm.
Thank you so much, Samar. And next, I'd like to welcome Esther Hyun. Esther is a board member of Colon Cancer Stars, as well as a colorectal cancer survivor. So, Esther.
Thank you. Before I share my story, I want to take a quick selfie. I share my story on Instagram as parenting with cancer, so I gotta document this. So when I was diagnosed early last year, one of the first thoughts I had was, am I going to see my 1-year-old and 3-year-old grow up? Will they even remember me? Then I asked myself, how could this happen? What could I have done differently? During the years leading up to my diagnosis, I ran a half marathon. I didn't drink. I didn't smoke. I didn't have any pain. I had 2 perfectly normal pregnancies. So if there was something serious going on with me, like cancer, I would have known, right? Or the doctors and midwives and other providers I met with would have been more alarmed or asked more questions. At my last postpartum appointment, the person weighing me was shocked to see how much weight I had lost. I actually reassured her that this was normal because this happened the first time I got pregnant and gave birth. I lost almost 30 pounds in 6 weeks after I gave birth. I spoke with the midwife that day, and like similar to the first time I was pregnant, she attributed it to most likely breastfeeding. She didn't ask if I had blood in my stool or if I had any bowel movement changes or anything like that. Instead, she simply asked me, "You feel fine, right?" Of course, I feel fine. I would prefer to sleep 12 hours every day, but I have a newborn at home. I'm breastfeeding every 2 hours. Of course, I'm exhausted. I often had constipation and diarrhea and blood in my stool, and I had mentioned it before, and I chose not to mention it then and there because I already talked about it. It was probably not really relevant, and this was probably my normal. After I got diagnosed, I heard colorectal cancer advocates preach that if you have symptoms, you should go get a colonoscopy. Not do a fit test or a blood test, go straight to a colonoscopy. And yet, despite having more than one symptom over multiple years, I saw at least 4 different providers at 4 different times, and I specifically asked 4 different times for a colonoscopy and a referral to a GI. And it finally took years to be diagnosed. Looking back, I wondered if I would have been stage 1, 2, or 3 if I got that referral that I asked for. But I also wonder if it would have been a trade-off for the children that I have now. Getting a colonoscopy when you have symptoms and you're under 45 is easier said than done. Some early onset patients I've met with have told me they feel like they've experienced medical gaslighting. Me, I'm not so sure. I don't think any of the providers I met with were dismissive of me and my symptoms, but I certainly believe they were dismissive of the idea that a young woman could have something more serious than hemorrhoids or postpartum weight loss. Because statistically, not a lot of people get cancer at my age. So it's probably something benign. In law school, I learned that defendants are supposed to be innocent until proven guilty. Perhaps more doctors should see their patients as sick until proven healthy. After my diagnosis, I sent a message through my chart to my midwives, letting them know I was diagnosed with stage 4 colorectal cancer. I wasn't sure what to expect from sending that message, but I hope that the next time that they see a pregnant woman with anemia or a new mom with significant weight loss, they'll pause. Maybe ask a few more questions before rushing to reassure her that this is all normal and probably nothing. Maybe one day there'll be one less mom asking herself today, what could I have done differently? Thank you.
Maybe I can start with Esther. Thank you, first of all, for sharing your story. You mentioned the delay in diagnosis you experienced, a lot of survivors experienced. So I think from your perspective, what do you hope that providers would ask you or they should know about when patients present with symptoms that could be consistent with colorectal cancer? Because we recognize, as you said yourself, that a lot of the symptoms can be non-specific. It can be related to hemorrhoids, which may be why people are thinking about that. But what would you want them to know? What would you want them to ask their patients?
Yeah, that's a great question. And that's something I've thought about before. And I think one thing is that a lot of doctors want to reassure their patients, and I think there's a right way and a wrong way to do it. In particular, right before I got diagnosed, I actually made an appointment with 2 different doctors at the same time because I've had all these past instances of being told you don't need a colonoscopy or come back later, even though I had done self-remedies at home of cutting out dairy and wheat and things like that. And the first provider I met with, she kind of gave me the same message other people have told me, which is it's probably because you're breastfeeding or whatnot, but we can do some ultrasounds and blood work, things like that, do a stool test. Then I went to the second provider, who happened to be Asian American, and instead of reassuring me that it was nothing, she said, you know what, I don't know if it's something serious or not, but let's do these blood tests, let's do a fecal test, and see what's going on. And I think the reassurance, the way each of these providers addressed my concerns was very different. One was, statistically, it's probably nothing, but we're gonna do this. The second one, even though they were essentially recommending the same next steps, gave me confidence because she was like, let's find out answers instead of jumping to a conclusion that it's probably nothing. And so I would say to providers, we're all human. You don't have a crystal ball, so let's not jump to the conclusion that it's nothing. Let's be more open-minded when you communicate with them, because your patients they don't need reassurance about something that isn't certain. They need answers through, tests and whatnot. Secondly, I would say I want to share one of my favorite TV shows is Law and Order SVU, and if you're familiar with Olivia Benson, she'll often ask victims, is there any detail, no matter how small, that you may have not shared that you want to share with me? And that's what I would recommend providers to do, to be Olivia Benson and talk to your young patients and ask them a question like this, because most likely they've seen other providers, been told that these symptoms are, normal or not a big deal, and may just realize it's not, maybe it's not relevant for me to share it again, because before I was told, I was reassured that it was nothing. And so be a little bit more inquisitive. They may not be necessarily sharing everything that's going on with them. So those are the 2 suggestions I would have. Yeah.
Thank you. Samar or Christina, as providers, do you have anything you want to chime in about?
I think really listening to patients is something that all providers could probably work on, but your statement about asking again, is there any small detail? I find that sometimes if I see a patient 2 or 3 times, it's not till the 3rd time that I see them, they're like, by the way, I didn't mention to you before, but I want to tell you now. And when they say that, I'm like, oh man, I wish you had told me that before. So I think that's great advice for everybody, that really try to make sure that we tease out every symptom so that we have a full picture versus just kind of okay, I think it's this, but not really giving the patient enough time to or making them feel safe enough that they can provide all the information to us. So thank you.
Can you hear me? And I think part of the problem too is that, as I alluded to in my talk, Asian Americans are viewed as this model minority. And this myth is pervasive that, Asian Americans in general are these high achieving communities relative to the US population. And when we see health statistics like we've seen earlier, in aggregate, Asian Americans seem to have a lower burden of cancer. And perhaps that's kind of spelled out in other diseases as well. And I think that lends itself into clinical care, that sometimes that there are these implicit biases with providers that think that Asian Americans are generally very healthy people, and they're not, when they bring symptoms like rectal bleeding up, there's sometimes this bias that it's probably hemorrhoids because we believe that Asian Americans in general are very healthy. And I think this goes back to the issue with the data that we have that's really problematic, which shows Asians overwhelmingly in aggregate. And a big issue in the research community is that we don't know enough about disease outcomes, exposures, risks in individual cohorts, in individual Asian origin groups, and that's definitely a direction we need to start moving towards.
A question for Samar. So, we saw data that Christina presented that Asian Americans on aggregate have one of the lowest colorectal cancer screening rates in the US, and Becky presented earlier that Asian Indians have one of the lowest rates among the Asian American population, 44%, right, compared to 70% of the general population. So you have a lot of Asian Indian or South Asian kind of patients that you care for. So is there any kind of specific barriers in that group that is different than what we've talked about kind of in general that you want to identify?
Yes. So I think the biggest barrier is just lack of awareness of colorectal cancer and this thought that, well, I eat fine and I don't have symptoms, or even if they are having symptoms, I haven't heard about people having colorectal cancer in my family or in my community, so I don't need to worry about that. So really educating patients on the prevalence of colorectal cancer in the community, and that screening is important even if you're not having symptoms, because you could still have a precancerous polyp or something like, that needs to be attended to. Another thing is the distrust, I think, in the medical system is much higher, in my experience, in the South Asian community than I have found in other communities or other patients, because they just feel that we're out to get your money, or if I start coming to see you, even if I have nothing wrong, you're going to find something, and then now what? If I hadn't gone to you or hadn't had this screening test done, I wouldn't have known, and then I wouldn't be in this situation. So really trying to gain the patient's trust, which is much easier said than done in some situations, is different versus other populations. And third is just the I think sometimes language can be a big barrier. Not everyone is able to understand in English what is going on, so being able to speak in their native tongue can make a huge difference. And I realize that's not possible for everyone. Having an interpreter there can be helpful. Sometimes, and I know it's not always possible, having a family member looped in, that can make a difference, because having an interpreter and a family member there can make things a little bit more human versus just from an interpreter. They just interpret word for word, so sometimes the empathy can get lost in that translation. So looping in family members is helpful, but definitely trust and building a relationship with the patient is going to be the biggest factor.
Yeah, I really was interested in your first point about that just because they're healthy, right, they can still get colorectal cancer. And I remember the NCCRT actually did a kind of a book messaging about what are the messages that resonate most with Asian Americans. One of the ones that was, Asian Americans get colorectal cancer. So, just because, you feel like you have a healthy lifestyle, right?
Yes.
That this is still just a highly prevalent disease. So you don't need to have any of the most kind of the risk factors we do talk about.
Right, and getting word out there in the communities that we do get colon cancer. Like, it's not like that Southeast Asian or South Asian people are immune from it. So making it more known and talked about in the community, whether that be in like community settings and places of worship somewhere, so that there's more awareness of it. And when people talk about it, it takes the stigma away, and that makes a huge difference when it's more normalized. I think you touched on that as well, where it's not so much of a taboo topic anymore. Whereas in a lot of, with Southeast Asians, you don't talk about that part of the body, and so once it's more normalized, I think that would make a huge impact as well.
Thank you.
I also wanted to add for the education part, I don't think it's just teaching them about symptoms, but also that they can be pain-free symptoms. And I think the notion that you have to go to the doctor when you're in pain prevents people from going to see the doctor frequently, because it's like, I'm not in pain. This is a transient symptom. And so I don't really need to go see the doctor because it went away after a day.
Yes.
And I think that's part of the education as well.
Yeah, 100%.
Excellent point. Christina, I want to ask, so you presented data that in terms of epidemiology, while screening the Asian American population is lower than the other groups, colorectal cancer incidence or mortality is lower, it's better, right? So what would you say to people, say, if that's the case in aggregate, then why do we need to focus on this group?
Yeah, no, I'm glad you asked that question, Peter. And I think, as I mentioned earlier, this hints to the broader issue of how Asian Americans are evaluated in research. Overwhelmingly, and when I was getting into this work, I was shocked to see that there was so little on individual Asian origin groups in terms of disease course and whatnot. And that SEER study that we displayed that showed that when you disaggregate Asian Americans, that Japanese American and Pacific Islander men actually had comparable rates of colon cancer to Black men. I think that really drives the point home that we need to stop evaluating health outcomes, health risks in Asian Americans in aggregate, and that we all know that Asian American is a very broad term that encompasses over 40 different groups that are vastly heterogeneous across lifestyle, socioeconomic status, multiple factors. And so we need to move away from those broader racial categories and start to evaluate these kinds of disease processes and health status in these individual groups, because these factors are so different.
Esther, I want to come back to you and ask, from your own experience, do you feel there's any difference in your experience as an Asian American in your diagnosis and treatment journey?
Well, I think I need to first share a little bit about my background in order to answer that, which is my parents immigrated from Korea, and I learned after being diagnosed that Korean Americans have a high uninsured rate, and that was the same for me and my family. I grew up with no insurance. I didn't get insurance till I was in college, and I really didn't know what to do with it. I barely used it. My parents were small business owners, and so while we weren't money poor, they were time poor. And so I also saw that growing up, which is you only go when you're in pain or something severe. And also I saw my parents working so hard, and seeing that, I tend to not complain as much. I would, just kind of work through pain or discomfort. And so I feel like because of that, it affected my diagnosis, because I didn't go to the doctor as frequently. When I did go, it's because it was a big issue, but the provider didn't recognize that. He doesn't know me, and the fact that I'm even coming to you is a big deal. I don't think they recognized the significance of that, and said, one of the providers told me, oh, you cut out, like dairy and wheat, that's great. Why don't you keep doing it? And if it's still an issue, come back. It's like, no, I took all these steps before I even came to you. You're kind of the last step on my journey here, and you're not noticing this. And you're telling me, oh, it's probably nothing, go back and do this. It's like, you need to realize that this might have been your only opportunity to really speak with me and help me. And I might not have gone back to another provider for a long time until those symptoms kept getting worse and worse. And that's exactly what happened in my situation. Also in my treatment, I didn't really complain of a lot of the symptoms because I went in to doing chemo radiation, and then later surgery, expecting pain and expecting discomfort. And so I had this incident where I was getting compazine, and then I got some liquid IV fluids, and I started feeling like really antsy, and I was like, I need to pull this IV out, like I need to get going, but I just kind of stuck it out. I was like, no, I need to do this. And I went home, and then it happened the next time on my next disconnect. And then I asked the nurse, I was like, what did you just give me? And she's like, oh, I gave you compazine. I'm like, I feel this urge to want to get out of here. Like, I feel so anxious, and I'm not an anxious person. And so she was like, oh, this is actually a really rare side effect of compazine. And it's like, oh, that would have been really great to know. And the fact that I even happened to ask, like, what were you giving me is like, made me realize that I can't let these minor things go that I think is not relevant or not a big deal, because that didn't really give me pain or hurt me, right? It's not like I had extreme nausea, but it was this weird feeling. And so I'm glad the second time I, listened to my self and said something, but it's like, because of my experience growing up of, you only need help from a medical professional when you're in pain or you're really hurt. It really influenced both the diagnosis and then eventually my treatment process as well. And I'm basically unlearning a lot of that. I'm still learning, how to advocate for myself and change the mindset I had growing up, without insurance and without really consistently going to see a doctor and have this team that I work with that I have now.
Thank you for sharing that. Yeah. I'm just gonna ask one more question before we turn it over to the audience. I'm sure there's lots of questions there. Samar, I want to ask, so you mentioned that you also have a lot of patients who are first generation, I think immigrant kind of patients. So when you see someone in your practice, aside from all the other multiple medical problems they have to deal with, you're talking about, say, colorectal cancer screening, do you approach people, do you keep in mind kind of their immigration status, their language proficiency, their cultural background, and how does that frame kind of the way that you approach something like colorectal cancer screening?
Definitely. When I have a patient come in for the first time, I try to ask them, regardless of what the appointment was made for, what brings you in today? What is going on with you today? What would you like to talk about today? And that really will set the tone for the visit, because that allows them to explain to me what their concerns are. And when you do that, that builds an understanding between the patient and myself, and allows me to kind of get an understanding of what they understand about their health. And then from there, I can, once we've kind of addressed their symptoms or whatever concern they have, I find that then it's easier for me to bring up, okay, well, have you thought about, doing cancer prevention screenings? And so that segue, it becomes much more smooth when I do it that way versus being like, okay, we're here for your physical. Have you done a mammogram? Have you done a pap smear? Have you done a colorectal cancer? Because they're like, well, what's a mammogram? What's a pap smear? So it really is just kind of first listening to the patient. And I think that could go to any type of population, but especially an immigrant population, because they are very hesitant to come to the doctor. If they've come to me for an appointment, then there must be something going on. It's not just because they want to check, their cholesterol that day. So that definitely makes a huge difference. And then, just taking things slow to build a relationship, because maybe the first time is not the best time to talk about these screenings. Maybe we have them come back, and then once they feel comfortable, talk about, cancer prevention, because even the word cancer, for all of us is a scary word, but it's not something that's commonly talked about back home for people. So definitely that's how I would approach it, a little bit differently from someone who may not be an immigrant or Asian or Southeast Asian.
Thank you.